So both Erin and I are going to cover the use of information technology and how we approach things at Imperial. I think what we're going to cover is where we've got potential applications for technology. Amir gave a wonderful talk earlier about advanced technology, which perhaps is not yet available to us in the clinical area. I'm going to talk about some basic examples and then how we implemented it. We all live in a huge information age at the moment. The world is incredibly interconnected. This is partly how COVID spread, but of course everyone is now completely and utterly addicted to their phones. And whilst everyone is normally looking down at their screens and not really looking what they're doing, perhaps we can leverage this addiction level to be able to treat our patients better. So looking to see how IT combines in these 4 different spheres, looking at how we can apply for patients, staff, infrastructure and disease. We can identify a number of different areas, particularly with outpatient and inpatient care, our approach to having meetings, stopping physical meetings and going entirely to a virtual meeting, trying to maintain a constant dialogue amongst staff. At the moment, we're all practicing social distancing. UK is currently in lockdown and therefore we don't have ease of access in communicating. We must maintain our morale in this moment. There's been huge issues in transport within London. There's been a huge reduction in the availability of the London Underground. There's been a reduction in train services, and this means that staff cannot get into work. And I know Rationale will be speaking a little bit about this later. Plus, we can use IT to help get our clinical updates and even perform major studies, which I'll briefly touch on. So Erin is going to talk a lot more on this in a moment, but one of the things that we did very rapidly at Imperial was to alter our paradigm for outpatient appointments. We stopped face-to-face appointments, went to telephone only or video appointments, and this was remarkably well done. Patients were all told to attend the appointments at their scheduled time in the normal manner. We use a variety of different systems. Attend Anywhere is one that's provided by the NHS, and we leveraged off that. We've also used telephone clinics, which have worked very well, particularly for our older patients. And now, as the crisis is developing significantly, we've moved into doing entirely virtual clinics. So we are reviewing the patient's data and investigations, as well as direct access into GP records to be able to provide the information that GPs require for patients that are normally managed in secondary care. For our inpatients, we've progressively moved on to using video technology to be able to make MDTs much easier. You'll see here in this graphic that we have a mobile computer system which has a very high resolution computer camera, allows us to be able to communicate with the operators in the dirty cath lab. So we've earmarked different cath labs as being relevant for COVID positive or negative patients. Once patients are in that lab, they can't then come out until the pathway is clear. We found after our first few cases that communication was very challenging, but this was solved relatively easily by providing a video technology that allows us to communicate. On the graphic there, we can see Chris Baker having a discussion with Ricardo Petracco, the previous speaker, and they were having an MDT discussion about how to manage a ACS presenting in a COVID patient. Something that we've never had to really deal before is that a large number of patients are now unfortunately passing away whilst on the ward without having access to relatives being by their side. This is clearly a very difficult and emotive time. You will have seen stories in the news of how nursing staff have used technologies such as FaceTime or other video platforms so patients can talk to their relatives remotely. This is something I think we're going to have to think about more and more as time goes on with this pandemic. And we are using this Zoom technology ourselves. So it's not just our colleagues at government, Boris Johnson talking with his COBRA committee there, but we have been having daily Zoom briefings amongst staff at Imperial, amongst different teams that we've been broken into to discuss, strategize our approach to this condition. And I think this is a readily available technology, which has now been approved for NHS use, although there are some concerns over its potential for leaking data. Virtual conferences, just as we're doing now, I think are incredibly important. You can see here my colleague Sunta Kanaganaigam on a conference call with Wuhan in China, where we had a very detailed discussion with a major cardiac hospital that gave us a huge amount of advice. We've done this with centres in Italy also, and I think most centres around the world are using this approach to gain insights from our colleagues around the world. More simply, we've been communicating and maintaining each other's morale by using simple messaging platforms such as WhatsApp. This is a quick and easy way of getting information between us and has really altered the way we communicate. But because it is not necessarily secure, then technologies such as Silo is a GDPR compliant app which allows us to be able to share raw patient data and allows us to make rapid decisions. And we've had a Silo conversation just this morning about an unwell patient on the ward. Now, I know Rationale will be speaking a little bit later about some moves on logistics, but technology can clearly be leveraged in getting our workers and staff into hospital. Now, Uber is clearly a platform in the UK. Difficulty has been that some reports of Uber drivers not coming to hospitals because of fears of COVID. This has been solved by work with London Black Cabs, which have remained the complete stalwart behind all of our infrastructure. Finally, just before we move on to Aaron, we're going to just briefly touch on how Twitter has really helped us. The information has been coming at us thick and fast. It's very difficult to pass all of it. But what we found, Twitter has really helped with sharing that information and getting peer review. Ricardo showed our PPE approach. This was actually had rapid peer review on Twitter, and it really meant that we were able to get that information out there and share it with colleagues around London, UK, and around the rest of the world. And just before I move over to Aaron, I'm going to mention the COVID-19 Symptom Tracker app. This was developed by academics at King's College and together with a company called Zoe, and they are encouraging patients up and down the country to share their symptoms with in an anonymous manner on an app. And this has allowed some unique insights. In particular, it's one of the few technologies that recognize that anosmia was a key feature of COVID-19 and is particularly sensitive in picking up this underlying condition. So I'm going to hand over to Aaron, who's now going to talk a bit more detail about our inpatient work.
So, as I said, I'm Aaron Arnold. I'm one of the research fellows here at Hammersmith Hospital, and my role's been partly involved in setting up virtual working for us. So the rationale for working virtually is mainly for two reasons. The first reason is that you've got a mixture of confirmed and suspected COVID patients and a group of patients with a low likelihood of COVID, all mixed together in the first phases of the COVID wave. And so if you've got large ward round teams, you're increasing your chance of transmitting from COVID patients to non-COVID patients. And of course, we have healthcare workers who seem to have a higher risk of getting a severe manifestation of COVID-19. This could be for a multitude of reasons, but if we can keep them out of contact with COVID patients with virtual working, that's all the better. So we combine electronic patient records with video conferencing software to perform virtual ward rounds. Our electronic patient records is Cerner, which many of you will already be familiar with. Now, this allows us to do prescribing, documentation, and check results all through the software. So that allows a lot of remote working. Other versions of this software, or other licenses and other different kinds of software don't have quite the same level of functionality sometimes, but you can always make it work with what you have. We then combine this with video conferencing software. And again, there are differences depending on which software you're using, as well as which hardware you're using. So we use a setup with tablets using Microsoft Teams, which we've found very useful. You can use software, but the restrictions placed can be different. And so it's just to be liaising closely with your IT team, really. So the most important slide is really this one. These are the principles of working virtually. The most important one is to ensure that there is no movement between the clinical areas and your remote working areas, because you're only really clean when you arrive. You should enter the virtual working area. You may then proceed to a clinical area, but you must not return to a working area to maintain that virtual working area as a COVID-free zone. You should set up strict cleaning protocols to make sure everyone is cleaning the tablets with Clinell wipes or other equivalents, as well as all the computing equipment. You should be very closely liaising with your IT team to open up your Wi-Fi bandwidth and access. You'll find there are probably restrictions in place that you need to overcome. And a key point is to get buy-in from the whole team, including some of the less tech savvy or more tech phobic members. Those might be the members who are perhaps slightly more senior and actually have the most to gain by staying away from the shop floor and actually the most to gain from working remotely. And finally, just an example of how it's worked for us, we have a setup with the consultant, Dr. Carla Plyman, here working remotely, with our registrar, Nickel, here on the wards donning his PPE, about to go and see a patient, and Angela, one of our ANPs, who's documenting and helping out with the ward round completely remotely. So there's only one member of the team who's actually patient facing, and we've got other members of the team contributing from their virtual environment.